Right. Well, welcome back. So I'm part of the Evidence Policy and Evidence and Influence Collaborative that Lisa Barrow started, and Barbara's continuing. Well, Barbara's not here yet. So I'm delighted to be able to introduce day 2, and we have a great lineup, particularly this first session, well, for the whole day, but I'm very excited about this first session on commercial determinants of health, which is an area that I'm very interested in. We have 3 speakers this morning who are speaking about 12-15 minutes each. So we'll probably have time for maybe 1 question after each speaker, and then perhaps 10 or 15 minutes at the end for a broader discussion.
Thanks for having me. My talk today on commercial influences and public health research. To start off with, just want to pay my respects to elders past and present and emerging of the traditional owners of the lands that we are currently on today. And also just really quickly just want to pay tribute to we recently lost someone who was a real champion for NCD prevention, which is the area in which I work in, and he was also a fierce advocate for mentoring EMCRs like myself, and he would be so pleased to see so many EMCRs presenting at conferences like this. Okay, so just a real quick introduction to my background and field of study. I tend to focus in non-communicable disease prevention and primarily in the translation of that research into real-world practices. But we stumbled upon, the commercial influences on these risk factors, and so that's led us to really start to think about what are the impacts of commercial influences on public health academic publishing. So how we came about this was actually a study that I did for my PhD, which we wanted to look at particularly in the area of physical activity. And some of you might have been there at Adrian's workshop yesterday on the commercial determinants of physical activity. But to what extent are the publications in physical activity actually promoting the translation of research from, so that we can scale effective interventions up? But what we found was that over several decades that public health research in physical activity is still predominantly descriptive research, which is not super helpful if we want to scale things up. So they're primarily cross-sectional studies, very few interventional studies, and even fewer scale-up studies. But what we really did find, and right at the start of the project, that there was a massive increase in the volume of physical activity publications over the decades. So then we put that question aside for a little while and came back to this after I finished my PhD. So just really quickly, what we do know about some of the drivers of academic publications. So researchers, so people like myself, scientists out there, yourselves, and we are really motivated by our desires to do the good research and then disseminate our findings. So we really want to disseminate our findings, and the primary ways traditionally is through academic publishing. However, we are also motivated by we either publish or we perish. In order to progress in our careers, we do have to keep publishing. Another sort of drive of academic publishing, and this is increasing over the years, is actually grant agencies. So a lot of the grants now that are being given out have a mandate that you have to publish in open access journals, because the intentions behind it are very noble. They want this information of the research they're funding to be free and accessible for all. And also this is reinforced at a conference I was at on Monday by the NH and MRC, who say that that's actually one of their big sort of key strategies. They want to keep driving more and more publications in open access journals. But no surprises here, another really key driver, I'm sure you've seen most of these before, are the commercial publishers. And unfortunately, unlike researchers ourselves and even grant funding bodies, they are not as altruistic. They are mainly motivated by increasing profits. Okay, so the research questions we really wanted to answer was we wanted to look at publication volume over time, specifically for 4 key public health risk factors, the newer sort of risk factors like physical activity and obesity, and also some of the sort of more well-known risk factors like tobacco smoking and alcohol. And we were hypothesizing that some of the drivers of the increases in publications were really due to journals and their different characteristics. Okay, so the methods, just really quickly, we conducted in conjunction with our librarian, we developed a search strategy and we conducted a search in the Web of Science database. And we then categorized our results by 3 periods. And you can see quite clearly the first period is the pre-open access, where journals were traditionally published by subscription only and prior to any online publications. Period 2 was the start of the online revolution and open access, and period 3, which is the last decade, where online open access mega journals really took off. We also conducted some reliability between the co-authors, where we just wanted to make sure that the publications we were looking at were indeed related to the areas we wanted to the 4 key risk factors. And we also collected additional data on the top 50 journals within these 4 key areas on the publisher type. So whether they were published by a disease-specific society, or they were endorsed by a scholarly society, or were they published primarily only by a commercial publisher. Their publishing model, which you might be familiar with, whether it's a traditional subscription-based only model where you pay, or your institution pays for you to access the publications, and then increasing the hybrid, where it's partly paid, and also open access, where it's free and available for all online. We also looked at a few other factors, years in publication, and also we tried to classify these journals as well as if they met the criteria for mega journals. And I'm not going to go into the criteria. Suffice to say that one of the biggest criteria is the volume of publications. And what did we find? I guess no surprises here. We saw a very marked increase in publications across these 4 key areas. And you'll notice by periods, you really start to see it take off from period 2 onwards. And also, interestingly, the increase, so I'll just quickly go through, it sort of hit 28,000 on average a year for obesity, 15,000 for physical activity, and then relatively at smaller volumes are tobacco and alcohol. But that slope of increase for physical activity and obesity was significantly greater than the rate of publications for tobacco or alcohol. Really quickly, that's the number of average number of publications per year. You can see for physical activity and obesity, much bigger than alcohol, tobacco. And a percentage increase, over 2,000% increase from period 1 to period 3 for physical activity publications, and 1,400% increase for obesity, and much smaller increases for alcohol and tobacco. We also noticed, and once we explored a little bit more about the features of the journals, we saw trends happening as well. So across periods 1 to 3, so period 1, traditionally, all the journals then were you could only access them via traditional subscription models. But as we move into periods 2 and 3, we were seeing that trend shift. So it was shifting very much so towards hybrid and fully open access journals. And what was really interesting is within the fully open access journals in period 3, more than around half of them were classified as mega journals. Again, similar trends, we were seeing a shift over time for journals that were published by or endorsed by a disease-specific society versus just pure commercial publishers. And this was happening across all 4 risk factors. And why is this a problem? So if we look at some of the features of sort of the traditional publishing models versus the commercial publishing models, so traditionally, journals were published or endorsed by disease-specific societies. They were very much driven by rigorous, peer review, and also there was a certain element of prestige attached to a lot of these journals. They often took longer from time of submission to publication. They didn't charge you to publish with them. They were largely funded out of their societies. Smaller volume of articles and the occasional special issue. Whereas in commercial publishing models, we see quite the opposite. They're obviously there for profit. Often they're broad, non-specific areas and much less focus on scientific rigor, quicker turnaround times, and I'm sure many of you felt the pain of the high article processing charges, large volumes of articles, and many commissioned special issues. And just to illustrate the differences in the volume of publications, so I'm sure many of you are familiar with PLOS One and Scientific Reports. They publish in excess of 20,000 articles per year. And in comparison with the sort of more traditional journals, you're seeing, they're all well below 1,000 articles per year. So that's quite a stark contrast. So what do these results mean? Really, I think it highlights the role of commercial pressures and tactics, and the number of special editions and guest editors. I personally have been invited to be a special guest editor by many journals. In fact, I've received promotions. I have been referred to as professor, apparently. So my supervisors in the room take note of that. Also, they must think very highly of me because I've been asked to be a guest editor on the Journal of Poultry Science. So I actually did look it up just for fun. But that also highlights the role of why do we feel the need to publish? It's because for our career progression, that publish or perish underlying theme is still always constantly running through the heads of us as academics. But this has a lot of implications for the field and just even for society as a whole. Increasing volumes of publications, if they're high quality and evidence-based and really help translate and make a difference in population health, great. But the reality is they're not. It does is they're diluting the evidence base. And Adrian said this yesterday in the workshop, is if you're a policymaker trying to sift through these hundreds and thousands of publications and trying to make a decision, this is just making things harder. And also it's increasing poor quality research. 2023 Nature found that there was 10,000 retractions. So again, wasting research funding, especially the government and the grant bodies who are funding open access research. And also in the age of misinformation, it's really, not helping the community value and also what we do as a scientific community. So what can we do? I don't have any necessarily solutions, but I know, we need to change academic culture. We need recognition by universities, and that volume of publications should not be the defining, priority for your career progression. Rather, we should really be focusing on impactful research that helps us translate, interventions from discovery to the real world. It's not all bleak. There are some steps now being taken. For example, we are starting to recognise there are some sort of really poor quality journals out there, and like Web of Science, Scopus has started to delist them from their databases, which is a good first step. And while we require really out-of-the-box thinking about how we can tackle this and not continually put sort of profits into commercial publishers, there are some new strategies coming out of the UK, Wellcome Trust, for example, where they're starting to, fund their own journals, their own open access research. And that's out of the research that they fund. They have their own peer review process, and they actually publish those findings for free. So this is really just a start for us, along with my partner in crime, Adrian, who has so many more ideas about how we can start really pushing this. We are wanting to conduct more research into the next step, which is understanding what types of research is actually being published in these kinds of journals and looking at the quality and seeing if there is a difference. Thank you for that.
Don't go away. We got a question that was very interesting.
Easy questions only.
Alex.
So just about solutions, I thought it's important to mention that AIMOS has its own solution. So Metaphor, it's a peer-reviewed platform that is not run by commercial publishers, that is established by AIMOS about a year ago, and we have a session down to tomorrow. Yeah, this afternoon.
Session on
and
AIMOS peer review this afternoon. Excellent.
Metaphor.
Yeah. Metaphor. Thank you.
Good plug.
Ranjan, we have an online question.
Yes, we have an online comment/question. It's a good presentation, but they're saying that you're missing the component of predatory journals in the story, and it's more complex, and they're saying worse than you think. And from a comment from Kathy, say just in reference to Metal, happy first birthday, Metal, with exclamation marks, but my voice is a bit bad, so I can't do that.
Yeah, so I should have qualified that, yes, we specifically excluded predatory journals because that's a whole other minefield that we weren't prepared to embark on just yet, because this was the first sort of foray for us. So that's why we looked at sort of more, recognized journals, but still ones that we are familiar with.
So, great study. And I had another question, which is whether, given the strong commercial influence on major public health, on chronic diseases, are you also going to look at funding sources? Is there a way that you can use, some kind of AI or machine learning to pull that out? I'm just thinking of it because of a small study that Lisa Barrow was involved in that found that sugar-sweetened beverage companies were funding physical activity research.
Oh, yeah. And anyone who was there at Adrian's talk yesterday, the workshop yesterday, would have seen, that's certainly permeating towards everything that we do in public health. We'd love more suggestions. Like I said, this is just really the first sort of study into this area for us. So we have so many things we want to do. Looking, and in fact, just from Matt's one today, is looking at the disclosure as well. That's another area we could certainly explore. Really keen on working with Joanna as well on how do we assess quality, because we're going to be making statements like this, that, there is some journals that are, just doing scripts research. We also need to qualify that by trying to have some assessment of quality as well. So there's certainly lots of ideas. Welcome them all. But yes, we definitely excluded predatory publications.
Thank you. We might save more questions for afterwards, because I'd like to welcome our final speaker for this morning, Akemi and Akihiko.
Good morning, everyone. My name is Akemi Hara from the Department of Biostatistics at the University of North Carolina at Chapel Hill. I'm still a master's student, and I'm also affiliated with the Medical Government Research Institute in Japan. And today, I will present our work beyond pharma, scale, concentration, and transparency of medical device. Industrial payments in Japan. And when we talk about the financial conflict of interest in medicine, I think the most focus is usually on pharma, but the medical device industrial is equally influenced in clinic products and practice, and much less examined. So in the next 15 minutes, I will talk about, I will tell you how large these payments are, and how concentrated they are, and why the current disclosure system in Japan provides only a limited transparency. Here's the roadmap, and I will begin with the transparency gap, especially on the device side. And then I will introduce our first national analysis of individual physician level payment in 2019, followed by the our expanded 2019 to 2022 industrial-wide data sets. Finally, I will compare the device and the pharma payments, discuss leader level COI, and close with stronger transparency might look like in Japan. Before we look at Japan, let me briefly express why device transparency matters globally. Medical devices are used in almost every treatment, like the stents, pacemaker, and endoscope, or robotic systems. And their selection depends heavily on physicians. But financial relationships in this sector are still largely invisible. For example, two coronary stents can look identical to a patient, cost very different amount, and cardiologist's choice determines which ones get implanted. So if that choice is influenced by financial ties, the patient would have no way of knowing. So it's not like the drugs and device-related risk get far less public attention, and many countries don't even have proper data set tracking their payments. So globally, the device sector remains a black box, and the lack of the visibility is exactly why we focus on Japanese case. And in Japan, farm and the medical device company follow the same voluntary disclosure guidelines. On paper, the framework looks almost identical, but in practice, the outcomes are completely different. And pharmaceutical company generally compare well. Their disclosure are frequently standardized, and there are among medical media attentions, which people call SEAC money. And researchers already use the data widely. And the device side is pretty different. I think it had inconsistently quality, almost no public pressure, and many disclosure published as PDFs that are extremely hard to do some analysis. And so even under the same rules, the level of transparency differs dramatically. And to fully understand Japan's situations, it helps to look at what other countries do. In the United States, transparency is legally mandated by the Sunshine Act, and all payments, including devices, go into one central researchable data set database. France have a similar statute systems, and the UK relies on voluntary reporting, but it's mainly cover farmer secular payments, so device information is very limited. Japan, however, is fully voluntary. There is no legal requirement, no central database, and disclosure are scattered across hundreds of company PDFs. So among G7 countries, Japan is the only one without a researchable and the statute system for device physician pigments. Before our study begins, so our first question was very simple. Just what do medical device pigments and to individual physicians actually look like in Japan? So to answer these, we collect disclosure from 66 device companies for 2019. This data was technically public, but everything was in PDF format. And each company used a different layout, so the biggest challenging was cleaning data. Yes, extracting thousands of the pages and the standardizing formats and the fixing inconsistencies. So in the end, we built the Japan's first nationwide individual level data set for device pigments, covering lectures, consultings, and the writing fees. And this gave us the first clean picture of the actual landscape. So the first result, what did 2019 findings look like? And device companies paid about 46 US dollars to physicians across roughly 60,000 transactions. But what stood out was the concentrations. The top 10 companies accounted for 63% of all payments, which Medtronic and Terumo far ahead of the others. Most payment went to cardiovascular and the surgery field, area where device choice heavily depend on physician judgment. So while the overall amount isn't very huge compared to the farm patient money, and the market extremely strategic and highly concentrated. And there's the next result. When we look at the individual physicians, we can see the figure is a classic long tail patterns, and about 3/3 received less than $1,000 in 2019. Over around 3% received more than $10,000, and just 7 physicians received over $100,000. So most physicians receive modest amounts, but a very small elite group capture a large share, showing how influence in device adoption is concentrated. Next, we look at which specialties receive this payment. And about 80% went to 3 spheres. And I think that makes sense because these specialties really rely heavily on devices, and their clinic decisions have major commercial impact. So company doesn't distribute payment unevenly, and they focus intentionally on the specialties where device choice matters most. So after understanding the 2019 baseline, we expanded the data set to 2019, from 2019 to 2022, and include 107 companies across both the device and the pharmaceutical companies. Over these 4 years, total payment reached about $947 million, almost $1 billion. And academic support was the largest category at 33%. Bringing all these voluntary PDFs together gave us the first cross-industrial multi-year view of financial relationships in Japan. And also, I figured out some interesting results. First, look at the left figure. Payments dropped by almost 30% during the COVID-19. I think at that time, surgeries was postponed. Conference cancelled, and in-person consulting stopped. But by 2022, the number have almost fully returned. So showing how resilient this system is. And second figure, yes, and the top 10 company across for about 7% of all payments. So although many companies disclose something, the landscape is really driven by a small group of major players. So the system that is both resilient and highly concentrated tell us a lot how insurance operates. And we also evaluate the transparency of device company disclosure from 2019 to 2022 and find major structure issues. About 2/3 of the PDFs were image scans, so they are not researchable. Formats were inconsistent, and no company provides CSV files. Most report only aggregate numbers, and around 95% didn't close or require recipient categories. So while the data is technically public, it's extremely hard to use. And the next, we look at the leadership of major medical associations, the people who write guidelines and influence national policy. Understanding these financial ties is especially important. We analyzed 80 association and 399 board members. The result was striking. 93.5% leaders received payments. Across 2019 to 2021, total payment reached about $16 million. The median was around $22,000 with a wide range, meaning some leaders received substantial amounts, and more than half of all payments went to just for society. And we also compare payment from device and pharmaceutical companies. Interestingly, both industrials pay the same leaders, but for different reasons. And device companies mainly target ophthalmology and the surgery field, where training and equipment choice matter. Pharma companies focus more on internal medicines and dermatologies, which prescribing and guideline developing are central. So the same leader appear in both data set, but through very different channels of influence. And when we compare presidents to other board members, the pattern becomes very clear. President consistently received 2 to 3 times more than money than non-presidents. Most payment to both groups come from pharmaceutical companies or device companies. The device payments become significantly higher. Yes, higher for president of surgery society. This suggests that leadership visibility itself attracts industrial engagement. Once someone becomes president, their influence expands and the company responds to that. And when we look at which company were paying association leaders, the pattern was very clear. On the device side, the top payers or major global players like Johnson & Johnson, Medtronic, and Alcon. On the farm side, it were large companies such as Takeda, Daiichi Sankyo, like that. And when we combine this list, we see that just about 20 companies account for almost all leadership level payment. So there isn't a board or decentralized system. It's a very tight network dominated by a small group of powerful multinational companies. So let me end with a few reflections. People often ask why Japan don't create a like United States create the Sunshine Act. But even in United States, an open payment hasn't eliminated conflict of interest, and in Japan, a legal system alone might not work as smoothly as we imagine. Professional responsibility is also crucial. Even with database, physicians themselves play the central role in managing conflict of interest, and patient trust depends on strong professional norms. And finally, public awareness. On the device side, there are very little attention in Japan, and without public interest, voluntary disclosure will likely remain fragmented and weak. So improving transparency really require all 3 elements. I think it's a better system, stronger professional standards, and a society that understand why transparency matters. And that's exactly what we aim to support through our End of Docs project. Not just by collecting data, but help building a foundation for real accountability. Thank you very much.
So much, Akemi. That was extraordinary, and I'm going to have to speak to you after to see if I can get some reference.
Okay.
Some of the things you've spoken about. Fantastic.